Okay, hi everyone. So I want to go over first the goals for this lesson. So I've pulled up your clinical psych packet just so I can show you where you should be and what we're covering today. So the goal is to define psychopathology, to talk about three symptoms that clinicians look for that may be symptoms of more significant mental illness, to talk about the difference between the medical and the psychological models, because those are models that we're going to be looking at as we move through the different types of treatments for different disorders. And just to basically give an overview of different types of therapies without getting into too many specifics. We're going to talk about the insight therapies, which are the more traditional talk therapies, the psychoanalytic and the humanistic approaches, really brief overview of the cognitive and behavioral therapies, because that's something that we're going to be getting into more as we talk about specific disorders. So really the only two pages that we're on in your clinical psych packet today are the first and second pages. So just have them open and ready to go. We're going to get started talking about treatment of psychological disorders. All right. So just to get us started, to define psychopathology, what this unit is about, what the clinical psych unit is about, is the study of mental disorders or mental illness. Remember that if any point in this video, if I'm going too fast, all you have to do is pause it, maybe go back, and get what it is that you need. Okay, so three symptoms of more severe or significant psychopathology are hallucinations, false sensory experiences, people who may see or hear things that aren't really there, delusions, disordered thinking, people who have persistently false beliefs, like, for example, of grandeur. So distortions of grandeur, meaning like they believe that they are the king or the president, that they're the most powerful person in the world, or sometimes delusions of paranoia, feeling like somebody or a group of people is always out to get them. And then what we call extreme affect or affective or emotional changes. So individuals with significant depression, anxiety, perhaps experiencing mania, or in some cases, like we're going to talk about with disorders like schizophrenia, an inability to have an emotional response, which is called flat affect. Examples of these will be covered as we move through disorders like schizophrenia, and then also a little bit in our discussions of bipolar disorder, where we will better define manic symptoms or mania. So the medical model, or the biomedical approach, focuses on treating disorders as diseases that have specific objective biological causes that require treatments with things like medications or psychosurgeries or deep brain stimulation. Concerns with this model are that in only prescribing medication and only attempting to treat the underlying biomedical or biological causes of the symptoms, is the person just becoming kind of a passive recipient of medication. So oftentimes what is usually done is that psychotherapy is accompanying any kind of medicinal treatment that a person is being prescribed. Okay, so this obviously, because we're talking about prescription of medication, we're talking about psychiatry, because we know that only psychiatrists are able to prescribe medication. Psychologists are not. The psychological model, which we're going to be talking about a little bit more today, it really combines a lot of the approaches that we've been talking about so far this year. It combines behavioral techniques with cognitive approaches, and we can refer to this as a social cognitive behavioral approach, because it's taking a little bit from each of the approaches in order to treat a person holistically. So it's looking, for example, at how social pressures might affect someone's thoughts that then might drive their behaviors. Okay, so the behavioral approach, focusing on abnormal behaviors that we can sometimes learn. It's going to focus on the importance of the environment and also how we can manipulate the environment through reward, through punishment, for example, in order to change someone's behaviors. The cognitive approach is about looking inward, focusing on how we perceive the world, how we think about ourselves and our relationships. Think about things we've talked about so far this year, like locus of control and self-efficacy and learned helplessness, and how all of these things might contribute to our thoughts, which then influence our behaviors. Most therapists, like I was saying, are eclectic in that they use a combination of all of these approaches in treating an individual client. So one example of this would be formulation. So looking at all of the biological and psychological and social factors that might be contributing to a patient's experience with mental illness. So I'm going to use this example, which was actually in a New York Times article last year about formulation and kind of, advocating for this very holistic approach to looking at a person's experience and then trying to treat them. So in this case, we have a 46-year-old single mother of 2 who presents with a 3-month history of depressive symptoms, including low mood, insomnia, and poor appetite with weight loss. Her condition was precipitated by psychosocial stressors, including unstable housing, credit card debt since the breakdown of her marriage 8 months ago. This is on top of a background of an introverted and passive temperament and a childhood in which her parents encouraged dependency. This was followed by a marriage in which her husband had complete control of finances. There's a strong family history of depression. Her mother and maternal grandfather were hospitalized for this condition. Protective factors include a strong network of friends and a willingness to engage with therapy. So what formulation does is it's focusing on 4 things, 4 factors: predisposing, precipitating, perpetuating, and protective factors. So our predisposing factors in this case would be something like the woman's temperament, which we know is something that we inherit. It's biological. Her family history would also play a role here. Precipitating factors would be, what are the immediate causes for the onset of her symptoms? Well, we have her going through a divorce, also losing or having unstable housing and credit card debt. All of these things perpetuating her experience with depression. Also focusing on the protective factors. So the fact that she does have a strong network of friends and she's willing to get help for herself. This is an example of where we would combine a medical approach or a biomedical approach, like perhaps describing antidepressants or SSRIs, on top of psychotherapy. And the goals of psychotherapy would be, for example, to raise her self-efficacy, perhaps to work on securing housing for her, for having her come up with a budget and finding a stable job, with the idea being that if we could do all of these things for this woman, that hopefully we could discontinue this cycle of hopelessness that she seems to be in right now, raising her self-efficacy, maybe improving her locus of control, giving her more of an internal locus of control, and also trying to prevent learned helplessness, which might lead her to just stop trying. So hopefully this example is a good example of how we would use both the biomedical and the psychological models in conjunction with one another in order to treat this person holistically. All right, so I'm just skipping ahead a little bit and getting to what else is important here. The Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, it's in its 5th edition, which was published in 2013. This was a big shift away from the DSM-4. It's not really important that you understand how it changed so much as you understand that this is published by the American Psychiatric Association, and it is what clinicians use in order to diagnose mental illness. This is where you would find all of the diagnostic criteria that we're going to be learning about for each of the disorders that we're studying. Alrighty. So, how do psychologists treat disorders? We're going to look first at the insight therapies. These therapies are focused on changing the person from the inside. So these are more like your talk therapies that you're probably familiar with, as well as cognitive therapies and behavioral therapies. These are operant and classical conditioning therapies that we will get into a little bit more as we talk about, for example, the treatment of phobias, exposure therapy that's used sometimes in order to treat obsessive compulsive disorder. And then finally, when we talk about major depressive disorder, we'll talk more specifically about cognitive behavioral therapy, which is a very commonly used form of psychotherapy. So again, our insight therapies are our talk therapies, helping people understand their distorted thinking, their emotions, and their motives. So under the umbrella of the psychodynamic approach, we have the psychoanalytic approach, which is actually not very commonly used in modern psychotherapy, at least not in North America. This is a very Freudian approach that places a large emphasis on digging into the unconscious, a person's past experiences. Some of the methods that are popular in psychoanalysis are free association, dream interpretation, and transference. So an example of free association would be a client coming into a therapist's office and the therapist saying to the client, "Tell me everything that comes to your mind." This might sound really easy, and at first you might just start rattling off a whole lot of things. You might start rattling off a recent experience that pops into your mind, or a dream that you've recently had, or a memory. But after a while, you start to notice that you actually do a lot of editing of your thoughts. You start suppressing thoughts or omitting thoughts that you think are embarrassing or maybe they're shameful. And what a psychoanalyst might do in that circumstance is say, all right, well, why are we stuck here? Because after a while, you might just stop talking. They would perhaps look at that as what Freud would call resistance, a place where anxiety is lurking. And then the therapist might start giving you some insight as to why you might be experiencing this type of resistance. So this type of therapy is very interpretive on the part of the therapist. And I'm making that distinction because the humanistic therapies are not interpretive. They're what we call indirect. So I just want to make sure that we make that distinction between psychoanalysis and the humanistic theories, is that one is interpretive and the other is not. This other technique called transference. An explicit example of this might be a therapist saying to a client, "Pretend I'm your mother." But I think what's probably more common is that over time, when engaging in psychoanalytic therapy, the client might start to take on feelings towards the therapist, feelings of love, feelings of anger, and the therapist will really try to kind of dig into those in order to uncover some experiences and feelings that the client is having and then address them. Psychoanalysis, like I was saying, is not very commonly used. However, psychodynamic approaches, which we're distinguishing between the two a little bit here, are still used in modern psychotherapy. The psychodynamic approach focuses on important relationships in a client's life, their childhood experiences, and also on the client-therapist relationship. So the goal of the psychodynamic approach is really to kind of reintroduce the client to themselves and to their feelings and try to uncover why they might be thinking and feeling the way that they are. To what extent are those thoughts and those feelings rooted in previous experiences? So that brings us to our humanistic approach. So I think at this point in the year, we kind of know a lot about the humanists. We know that their focus is on growth and fulfillment and self-acceptance and self-concept and awareness of the self. A distinction to be made here between the humanistic and the psychoanalytic approaches or the psychodynamic approaches is that the humanistic approach is not attempting to cure people. They're not viewing clients as patients. They're viewing them as people who are all capable of growth. There is more focus on the conscious than the unconscious, and more focus on the present and the future than the past, which we see more with the psychodynamic approach. So I told you last unit when we were talking about Carl Rogers that there is a whole type of therapy that is derived from Carl Rogers' work, and this is called Rogerian or client-centered therapy, that is not directed by the therapist, but instead is very much driven by the client and what the client wants to discuss. Some techniques that are used in Rogerian or client-centered therapy are active listening, also called reflective listening, where the therapist will kind of repeat back or mirror what the client is saying, check for understanding to make sure that they're getting an accurate perception of what the client is thinking and feeling. And remember, when we talked about Carl Rogers, we said that this therapy happens in a safe environment that promotes growth. So we talked about acceptance, unconditional positive regard being very, very important in the client-therapist relationship. The client knowing that the therapist accepts them unconditionally and is not judging them is really important. Acceptance, genuineness, and empathy are all hallmarks of this type of client-centered therapy. And I wanted to include this quote by Carl Rogers because I think it does a really nice job of kind of summing up what this client-centered therapy is about. He said, "I have noticed that the more deeply I hear meanings of the person, the more there is that happens. Almost always when a person realizes he has been deeply heard, his eyes moisten. I think in some real sense he's weeping for joy. It is as though he were saying, 'Thank God somebody heard me. Someone knows what it's like to be me.'" I included in the optional enrichment activities for today a quick 7 to 8 minute TED Talk called 5 Ways to Listen Better. And here are 3 tips also for more active listening in our own lives. This isn't something you need to know for the test, but just for life, I think it's important. These are important techniques. So if you have somebody who's being genuine and open with you and disclosing things to you, you can paraphrase. Make sure that you understand what they're feeling. You can repeat back to them what they're saying so that you're kind of encouraging them to point out any misperceptions that you might be having about what they're thinking. Invite clarification if there's something that someone's telling you, a feeling that they're having, and you don't quite understand it. Ask them for examples. And then finally, try to reflect their feelings. Like actually say to them, that sounds like it's really frustrating. That sounds like it's upsetting. And that can be something that's also an effective thing to do when you're, trying to be empathetic and really understand someone. So I don't want to get too much more into the cognitive therapies because we'll talk about cognitive behavioral therapy more when we talk about major depressive disorder. But I will at least give a very brief overview in that the cognitive therapies, as you would think, based on everything we know about the cognitive approach, is focused on our thinking patterns, our thought patterns. The goal is to reduce negative self-talk and to learn more realistic ways to explain the things that we're experiencing. It's going to focus on recognizing what we call cognitive distortions. So, for example, decatastrophizing. I think a lot of us have a tendency to catastrophize, which is that we think of the worst possible thing that could happen. For example, if we fail a course, or if we get a bad grade, we might stop here and ask ourselves, like, here's some cognitive restructuring, right? What's the worst thing that could happen if we fail a test or if we fail a course? Does it really mean if we fail a test that our future is now hanging in the balance and we might not get to have the career that we want to have? Another example is distraction. So helping a client find ways to divert their attention away from their negative thoughts or their negative emotions. And you could do this by having somebody count to 200 by 13s when they feel like they're becoming anxious. So here's some other examples. Just simply learning how to label distortions or be aware when you're having a cognitive distortion. And again, this is kind of a review of what we were talking about a little bit earlier in the year, which is also known as cognitive restructuring or a restructuring of thoughts. Couples or family therapy is something that I wanted to talk about. I think it's important to understand that when a couple or a family goes into therapy, the emphasis is really situational, not dispositional, meaning you're not going into that therapy and the therapist saying it's your fault or it's because of this person's personality that the family is having problems. It's much more situational than that. It's seeing the client as being the entire family unit. Each person is part of a system where one person's behavior influences the reaction of another, and so on and so forth. So in some cases, even in couples therapy, you know, they might find that one person's behavior is reinforcing the negative behavior of the other, and it's this vicious cycle that they might try to uncover in the course of couples therapy. All right, and then I think that this is probably a good place to stop, because we'll talk more about cognitive behavioral therapy and the other strictly behavioral therapies as we get to each of the disorders. So thank you very much for watching.